and welcome to this recorded webinar, which is an introduction to continuous glucose monitoring for primary care professionals. We do hope that you find this webinar useful and educational. If you do, please make sure that you like and subscribe to our YouTube channel so that you don't miss any new content that we upload. And make sure that you check out our website, Diabetes MNF, so that you can see which other events we have coming up that you might like to attend. Thank you very much and enjoy the webinar. So without further ado, I'm really pleased to hand over to our webinar host, Vicki. Vicki is a diabetes specialist nurse from the Leicester Diabetes Centre. So welcome, and over to you, Vicki.
Thank you, Hope. Thank you. Welcome everybody to this lunchtime session where we will provide an introduction to continuous glucose monitoring for primary care healthcare professionals. As Hope said, my name is Vicki. I'm a diabetes specialist nurse and I work within the Eden education team at Leicester Diabetes Centre, and I'm also part of the DSM Forum leadership team. So the subject today, I think you'll all agree, the world of diabetes never stands still. And advances in technology over the past 5 to 6 years has meant that we've all had to learn new things to help manage our patients with diabetes. And along with that, changes to the NICE guidance last year, we're all now seeing more and more people within primary care using CGM devices. So without further ado, let me introduce you to your speaker. Kevin Fernando is a GP partner at North Berwick Health Centre, and he has a special interest in diabetes, along with cardio-renal and metabolic medicine and medical education. He is also Scottish lead of the Primary Care Diabetes Society, content advisor for Medscape, and co-founder of the Goggle Docs. And if you don't already follow Kevin on social media, I would suggest that you do, because you'll learn lots. And also, if you fancy giving the DSM Forum a follow too, we keep lots of people up to date with all diabetes news. So over to you, Kevin.
Thanks very much, Vicki. Can you see my slides okay?
Yeah, we can see them.
Good stuff. Yeah, good afternoon, ladies and gentlemen. Delighted to be here to talk about, alongside Vicki, an introduction to CGM, continuous glucose monitoring in primary care. So thanks again for kind introductions from both Hope and Vicki. I'm a GP, as you heard, in North Berwick, just east of Edinburgh. Been a partner here, part-time partner for nearly 15 years now, but a wide interest in all things diabetes. And as Vicki's already alluded to, it's incredible, isn't it, Vicki, what's happened in the world of diabetes, CVRM over just the last few years. I was chatting to my GP trainee recently, and I was telling her about a paper I'd read a wee while back. So in the 1950s, the estimated time of doubling of medical knowledge was 50 years. In 1980, the estimated time of doubling of medical knowledge had reduced to just 7 years. 2010, the estimated time of doubling of medical knowledge was just 3.5 years. Guess what it's now, Vicki? Any idea what it's estimated to be anyway now? Doubling of all medical knowledge, not just diabetes.
No, but you're going to tell me.
Yeah. I don't know how they quite got this figure, but 73 days. Yeah. So it's incredible what we have to keep abreast of in primary and secondary care. I mean, what I love and hate about being a GP is you just don't know what's coming in the door next, do we? But the rate of evolution of knowledge, it makes it really difficult for us, doesn't it, Vicki, to match individual intervention to individual patient. Yes, we prescribe a lot of drugs, but today we're going to be talking about the use of technology for our patients living with diabetes in primary care. So these are my disclosures here. And just before I kick off, actually, I just wanted to share some resources, diabetes resources I've put together. Vicki mentioned I also work 1 day a week for Medscape Global and UK. So I've put together a number of what we call primary care hacks. So just clinical aid memoirs to make our lives a wee bit easier in primary care, but ultimately to help improve the lives of our patients. So I've got a QR code here where you can access all my hacks. So feel free to scan this. I'll share my contact details at the end. You can email me directly. So this is a CVRM checklist, cardiovascular, renal, metabolic review checklist for people living with type 2 diabetes. It is an aid memoir. Clearly, none of us can cover all of this in a 10-minute appointment or even a 30-minute appointment. But again, I just wanted to illustrate the breadth of experience of knowledge required now when looking after that person living with type 2 diabetes. And you probably won't be able to see it just now because I'm just flashing the slide up. But one tick box here is consider appropriate use of technology for people living with type 2 diabetes. And that's what we're going to develop on throughout this session. I've done one also on the NICE guidelines for managing type 2 diabetes. I'll be telling you a bit more about that in a minute with respect to technology. And then the updated joint European and American consensus on managing type 2 diabetes. And that biggie for many of us, the use of SGLT2 inhibitors is widening, isn't it, in primary care? We're using them for type 2 diabetes and now people without diabetes for things like heart failure and CKD. So I've got a wee clinical aid memoir there. That other perennial challenge, Vicki, isn't it? What next after metformin? I suppose in many ways it's getting a wee bit easier, isn't it? The metformin, SGLT2, and then when you can get hold of it, a GLP-1. In many ways, but we still use the other options. So, and then finally, prescribing in the context of renal impairment, kidney impairment, we do need to dose titrate medication. So if you have some time, please do have a look. These are all, I share them on my Twitter feed as well. Great. So let's kick off then. So type 2 diabetes in adults management. The NICE guideline was updated, well, originally published in 2015, long awaited update, wasn't it, up to last year. And the initial update very much did focus on a change in pharmacological management, of course, thinking beyond glycemia, as you can see from this nifty graphic I found online, a joined up approach to the management of type 2 diabetes, atherosclerotic cardiovascular disease, chronic kidney disease, focusing around early use of SGLT2 inhibitors. However, we had a significant update to that NICE guideline later that year too, into June, March, or was it June, I think, that really opened the doors to a wider use of CGM, continuous glucose monitoring, even for our patients living with type 2 diabetes. So this slide here, you can see what NICE tells us about type 1 diabetes. And it's a no-brainer here, isn't it? I'm sure even all of us who perhaps don't have so much experience in CGM know that CGM is standard of care, isn't it, Vicki, for our patients living with type 1 diabetes. Everyone living with type 1 diabetes should be offered either real-time CGM, so continuous, or flash or intermittently scanned CGM. And we'll be talking a wee bit more about this shortly. Don't worry if you're not so familiar with this terminology. But as I've alluded to already, what has really changed is that update to the NICE guideline just last year, June or thereabouts 2022, has opened the doors to CGM for a wider range of our patients living with type 2 diabetes. So that, to use an overused term, that is a game changer potentially, isn't it, for us, but certainly for many of our patients. But in true NICE style, it's not quite straightforward, is it, Vicki? There's a certain criteria everyone has to meet, largely driven by cost. And that is mentioned a few times. As I mentioned, I work in Scotland. In Scotland, we always used to think that NICE stood for National Institute for Curtailment of Expenditure, so rather than clinical excellence, because a lot of course, their recommendations are driven by cost, cost acquisition. So what did NICE tell us that when we might consider CGM in primary care for type 2 diabetes? So we should offer intermittently scanned CGM, so that's your Libra 2 device, flash glucose monitoring, to adults with type 2 diabetes on multiple daily insulin injections. So this caused a wee bit of confusion at the time. What do we mean by multiple daily insulin injections? So basically, anyone on 2 or more daily injections, and that could be a basal bolus regime as well. So, a fair number of our patients, okay? So more than 1 injection of insulin a day, if though certain criteria apply. If they have recurrent hypoglycemia, so symptomatic glycemia, if they blood glucose levels drop below 4, or they have severe hypoglycemia. So as a reminder, that's hypoglycemia that requires assistance of a third party, a loved one, someone else. Or if they've lost hypoglycemia awareness, so once their sugars drop below 5, below 4, they don't really get that flight and fright response, that adrenergic response, the tremors, the shaking, the hunger. They don't get these warning symptoms. They don't know they are hypoglycemic. So if you have patients like that, often, of course, goes hand in hand with neuropathy, long-standing diabetes. That also is a situation where we might consider CGM. Or if they have a condition or a disability, learning disability, dementia, vascular Alzheimer's dementia, meaning they cannot self-monitor their blood glucose by capillary blood glucose monitoring, then they could also use a device, or if they have a visiting carer or district nurse, they could have it scanned for them. Or another criteria, last criteria here is if we have advised that individual to self-check their blood glucose at least 8 times a day. So there might be occupational implications there. Someone working at height or driving regularly professionally, they may have to test very regularly. So these scenarios have been suggested by NICE where we might consider CGM in type 2 diabetes, okay? But there's a few more caveats here as well. NICE also tell us we can consider intermittently scanned or flash, as I said, glucose monitoring in our patients living with type 2 diabetes if they might need help from a carer or another healthcare professional to monitor their glucose. So I mentioned that already. My district nurses, I'm sure yours are the same, are under considerable pressure at the moment. They're visiting a number of patients who are unable to administer their own insulin. So if we can use CGM in this context, of course, can help us make decisions about the insulin regimes, reducing or increasing doses, and perhaps help workload of our district nurse colleagues as well. But here's a big point here that coming up next. We can also consider real-time continuous glucose monitoring. And Vicki's going to take us through some of the real-time glucose monitors. You might be familiar with a device called Dexcom One. It sits on the arm for 10 days and it just continually outputs blood glucose values. We can consider real-time devices, which you don't need to scan or flash, as an alternative to flash devices if they're available for the same or lower cost. Remember, I told you about those cost implications. And we do have devices available that are real-time devices that are at similar cost to flash devices such as Libra 2. And again, we'll talk about that in a little bit more. But very much we must remember, and I'm delighted NICE acknowledge this, CGM should be provided by a team with expertise in its use as a part of supporting people to, of course, self-manage their diabetes. And I think that, Vicki, is probably the biggest challenge for us in primary care, isn't it? Yourself, other secondary care colleagues have a wealth of experience of using CGM, predominantly, of course, for our patients living with type 1 diabetes. But now that it's coming into primary care, we're going to need support, aren't we? We're going to need to educate ourselves, hence webinars like this. And we've got to, of course, support our patients as well. They're going to have questions about technical questions about the use of the device, but also importantly, how to interpret their data, and most importantly, how to make meaningful change on the basis of that data too. So you can see big changes there in the updated NICE guidance in terms of who we might offer CGM to in primary care, particularly our patients living with type 2 diabetes. And we're going to expand on this as we go along. So very much you can see that key message is individualized care. One size does not fit all. I'm sure you'll all agree, primary and secondary care colleagues on the webinar today. Modern diabetes care is an art. It's not an exact science. We need to think beyond glycemia and look at all aspects: physical, mental health, support network, and adopt an individualized approach to diabetes care. And no doubt technology has a key role here as well, alongside, as I said, mental health support, pharmacological management, and lifestyle intervention as well. And this very much brings to mind one of my all-time favorite medical quotes by Sir William Osler, the late great Canadian physician. He famously said, "The good physician, or indeed nurse, pharmacist, dietitian, very much an MDT approach to diabetes these days. The good physician treats the disease. The great physician treats the person who has the disease. So very much encouraging us to take that holistic, person-centered approach. Treat the person, not the number, not the HbA1c. Okay. And that segues nicely with one of the key advantages of continuous glucose monitoring. And I'm going to go into a little bit more detail in a moment, but I just wanted to highlight a new metric, a new concept that we will need to be aware of in primary care when looking at, or when either considering initiating CGM or looking at CGM data. And this is a concept that I'm sure many of you have heard of already, time in range. So we're all well versed, aren't we, at looking at HbA1c values. HbA1c, as we know, is an average blood sugar value over roughly the last 2 to 3 months. And again, HbA1c targets have to be individualized according to comorbidities, frailty status. And, typically for a younger, functionally independent patient with little in the way of significant comorbidities, absolutely, we should be aiming for a tight HbA1c of less than 48 millimoles per mole or 6.5% in all money. But as again, many of you will know, HbA1c is not the perfect tool to assess glycemia, is it? There's a number of pitfalls we need to be aware of. One is anemia. I know not directly relevant here. If patients are significantly iron deficient anemic, their blood cells live for longer. So I'm sure it's still one of those useless facts I still remember from medical school. Red blood cell lives for 120 days. So if you have iron deficient anemia, your red blood cells live for longer, they circulate for longer, they're exposed to sugar for longer, so you get an artificially elevated HbA1c. So anemia is one factor, but also because it's an average, it doesn't tell you the day-to-day variation, does it, in blood sugar level, because it's averaging the last 2 to 3 months values. So this is what So this is what this slide shows. So I'm sorry, this is an American slide, which is why the units are milligrams per deciliter. But this shows 3 patients all with an HbA1c of 7%, okay, or 53 millimoles per mole, with an average blood glucose of about 8.5 millimoles per liter, okay? So if you look at the first patient, the first on the left, you can see this patient is experiencing huge swings, despite an HbA1c of 7%, huge swings in their blood glucose levels. It's dropping well below 70, so that's 3.9, so well into the hypoglycemic range, and then swings well above 180, so that's about 13. So hyperglycemic range as well. Huge swings there, of course, putting that individual at risk of significant hypoglycemic episodes. Again, very relevant if that person is driving on a regular basis. Then you look at patient 2 in the middle. Again, maybe not such huge swings, more time in range, but 2 big peaks there, above the 13 range, no significant hypos there. And you can see quite a significant proportion of time in that range between about 4 and 10 to 13. And then you look at that third patient, also with a 7% HbA1c, a much more even line there, really keeping their blood sugar levels within recommended target ranges from about 4 to about 10. Okay, so you can see, even though they all have an HbA1c of 7%, there's considerable variation, isn't there, in the day-to-day sugars. And that's where the clear advantage of CGM comes into play, because that can tell us what variation in sugars there are, and that can help us either titrate medications, change timing of insulin or other oral medications, and of course, most importantly, help our patients make meaningful change to these swings in their blood glucose levels. Because in essence, and I'm sure, Vicki, you agree, CGM is an educational tool, isn't it? Like blood glucose testing strips. I did prescribe blood testing strips even to my patients just on metformin on occasion, if I knew they were going to make meaningful lifestyle change according to what sugar levels they got. So a good example for that is, one of my patients, I remember from ages ago, told me, oh yeah, if he went for a brisk walk before he had his evening meal, he had a much lower peak after his blood glucose. But he didn't believe me when I told him that. He had to see it for himself, on testing his own blood glucose level. So he tried to introduce that on a regular basis. So he's made some meaningful change. So that's why I think the power of CGM as an educational tool has huge advantages to us all working as GPs, nurses, pharmacists, and primary care. But once again, we are going to need educated. This time and range metric is going to be very new to many of us in primary care. And Vicki's going to talk to us very shortly about interpreting, or some top tips, pitfalls for when interpreting CGM data. Because I've got to, even though I'm giving this talk, I've got to admit, I'm no expert in CGM. I bow to the wealth of experience of people like Vicki. But what I am is a GP with an interest in diabetes, starting to use CGM in some of my patients living with type 2 diabetes in primary care. And that's what I wanted to share today. So a bit more detail quickly then about time and range. So we have now international and national UK-based guidelines recommending that adults with both type 1 and type 2 diabetes should spend over 70% time in range. And that range, as I said before, between 3.9 and 10 millimoles per liter. So the green bar. So the vast majority of their day-to-day glucose variability should be within that range, okay? And they should have minimal time in that red range, hypoglycemia range, so less than 4%, between 3 and 3.9, and less than 1% at very low values, less than 3. And then on the other end, less than 25% of the time in a day, between 10 and 13.9, and less than 5% above 13.9. But of course, like medications, I said already, have to be individualized. Time and range has to be individualized as well, according to a person's comorbidities, frailty status, pregnancy status as well. And that's where we need to bespoke this bar graph as well. And this, again, I'm just introducing you some concepts here. I know some of this will be very new to many of us in primary care. But I just wanted to highlight some situations where we might bespoke that 70% figure. So as I told you already, most UK international guidance does suggest a 70% time in range for people living with type 1 and type 2 diabetes. But what about our older, more frail, higher risk patients? I don't know if many of you have been to North Berwick where I work. It's a very elderly population, popular place to retire. Nearly 30% now actually of my patients are over the age of 65 with a reasonable degree of frailty and a high prevalence of diabetes, type 2 diabetes too. So of course, in my older, more frail patients, like I wouldn't aim for a tight HbA1c with them, I certainly wouldn't aim for a tight time and range for them. I'd be much more relaxed. So actually, 50% time and range is appropriate perhaps for some of our more older, higher risk patients. And we can be a bit more relaxed about them going above 10, even towards 13. So we must, as we individualize therapies, we must individualize time and range as well. Because we don't want to do harm, do we? Yes, we want to reduce glucose variability, hyperglycemia, but we don't want to increase the risk of hypoglycemia. And very importantly, and I should have said this previously, every 5% increase in time and range is associated with significant benefits, microvascular, macrovascular, and importantly, quality of life benefits for our patients living with type 1 and type 2 diabetes. So I think that's a really useful take-home message there to illustrate the benefits of trying to reduce that glucose variability I showed on those previous graphs there. And then in pregnancy, particularly pregnancy where women living with type 2 diabetes or gestational diabetes, very tight time and range, 90% above in some occasions, because we want to minimize harm to mom, of course, but harm to wee one as well. So bespoke, like we bespoke therapies, bespoke that time and range as well. So looking further from the UK, I've taken you through NICE guidelines. What do American guidelines say? That joint American and European consensus report very much tell us that technology can be useful in people living with type 2 diabetes, but does need to be part of a holistic plan of care and very much supported by education. Again, education for people living with type 2 diabetes, but education for us as HCPs considering initiating CGM. And actually, they take a much broader view. They suggest in this joint American and European consensus statement, just updated towards the end of last year, consider CGM in all people with type 2 diabetes on insulin. So a much more broader range of patients. And perhaps we can touch on that in the Q&A. So just before I hand over to Vicki, just some key advantages. And I think I've covered a lot of this already. Essentially, I look at CGM as an educational tool. I mean, I think it definitely has the potential to help improve lifestyle changes. If patients can see their blood glucose levels change into perhaps lowering the carbohydrate content of their diet or stepping up their activity count, their step count, that, of course, can help motivate them to make further changes and give them a better understanding of their day-to-day diabetes management. As I said, CGM can help increase time spent in that glucose range, that target glucose range between 3.9 and 10. And that directly correlates with HbA1c. So an improved time in range, over 70%, reduces the future risk of micro and macrovascular complications of diabetes. I'm sure we all have patients who are terrified of nocturnal hypoglycemia. Many patients are terrified just to go to bed in case they get a hypo. CGM has a huge role there to allay those anxieties and improve quality of life as well. And CGM, of course, can be uploaded for consultations between us and our patients. So there's a number of platforms. The Dexcom devices use a platform called Clarity, which I think Vicki's going to tell you about. The Libra View is the platform for Libre 2, Freestyle Libre 2. And this, of course, can facilitate more effective and holistic diabetes review. But once again, and I appreciate I'm repeating myself, but this is something I've very much learned myself. It is a steep learning curve. I'm sure you'll agree, Vicki. The widening use of CGM in primary care does require education and support, again, for our patients, but also for us as HCPs. So I'll finish off just with a quick case study of who I've started on CGM recently, and also another couple of specific Primary Care Diabetes Society CGM resources. So this is Connor, 48-year-old patient of mine, just a young chap, Scottish Caucasian, BMI 31, non-smoker, young family at home, but he's working night shift. He's under a lot of pressure. His mortgage payments keep going up, as many of our patients are. And so he's working day shift and night shift as a care assistant in a local nursing home. He's been living with type 2 diabetes for about 7 years now, with sadly some complications already. He's got some non-proliferative retinopathy and some painful peripheral neuropathic pain. So we've had to escalate. He's a young chap. So I had him on triple therapy pretty quickly, actually, metformin, empagliflozin, and semaglutide. But unsurprisingly, as I'm sure many of your patients are struggling to get hold of that weekly semaglutide. I was still toiling with managing his complications, his HbA1c. So I phoned a friend, got my local diabetes consultant involved, and he was started on insulin as well. So he's on Tresiba, 48 units currently, and NovoRapid. Alongside his other cardiovascular meds, statin, lisinopril, indapamide, spironolactone, he has resistant hypertension, and duloxetine 120 for his painful peripheral neuropathic pain. HbA1c is still 66 despite all that therapy. LDL cholesterol 2.2. His home blood pressure average is pretty good now, 129/79. Renal functions, no. But we meet frequently. He's exhausted because of his working pattern. He's little time to exercise because of his shift work. His eating patterns are very irregular, and this causes recurrent hypoglycemic episodes. particularly on his night shift, and he's petrified because he's pretty vulnerable at night. There's not many people in the care home at night, so he's been checking his blood sugars 10 times a day, sometimes more, because driven really by the anxiety about hypos. And, you know, as a result, he often defensively snacks as well. So he was one of the first people I started on CGM, a Dexcom One device, a continuous device. I was able to prescribe that locally, and it's had a huge impact on his quality of life in terms of his anxiety, in particular, and his fear about hypos. His HbA1c is still elevated, so we're still working on that. But certainly, I felt the use of technology in this situation has been a very good step in the right direction. As I said, it's not a panacea to Connor's case. He's still got a number of complications, comorbidities we need to address, but I think it has been very helpful for him. So very quickly, before I hand over to Vicki, who's going to do a slightly deeper dive into looking at data from people like Connor. There's some great resources put together by some of my colleagues in the Primary Care Diabetes Society. So again, I put together a couple of QR codes, slides here, how to initiate and support CGM by my colleague Nicola Milne, like Vicki, another very experienced DSN. And then a quick guide to interpreting CGM data as well. So do have a look at these in your own time. But I'm going to hand over to Vicki just now. She's going to tell us a little bit more about some of the commonly available devices and differences between them, and also some top tips, as I said, and pitfalls to avoid when interpreting the data. And that's certainly one of my main concerns from colleagues. They are worried now that we're opening the doors to CGM in primary care. Are we, Vicki, going to get overwhelmed with all this ambulatory glucose profile data in primary care, and what do we do about it? Okay, so thanks everyone for listening so far. I'll pick up towards the end for the Q&A again, but I'm going to hand over to Vicki just now to talk about, as I said, interpreting real-time CGM glucose data.
Thank you, Kevin. So hopefully after today, it will all be very easy and simple. So I've already introduced myself. I don't need to do that again. So let's just move on the slide. So there are a number of real-time CGM devices now available. I didn't put this slide in, I probably should have done, but the DSM Forum have put together a comparison chart of all the different CGMs that are available. So if you pop over to the DSM Forum website on the What's New page, you'll be able to see all the different devices that are available. But I'm going to concentrate on two that are available to prescribe in primary care. I'm sure you all know about Freestyle Libra. It's been around for a number of years now, and we'll talk about some of the recent updates with Freestyle Libra 2. And then we've got the Dexcom One, which is a more recent addition to the drug tariff, which I think came out last year sometime. I do lose track of time because everything changes so rapidly, but they're both available to prescribe in primary care. Obviously, some of that might depend on your local guidance and what's on your formulary, but both are there to prescribe via the drug tariff. So the Freestyle Libra 2 initially was what we call an intermittent CGM, where people had to scan to view their current glucose level, but that's changed in the last month or so for those people using the smartphone on their, the app on their smartphone. It's now a real-time CGM, so there's no need for people using the app on their phone to scan anymore, provided they're using the most up-to-date app. So it will just send the glucose readings straight through to the app on their phone. If they don't have a compatible smartphone and they're using the blue reader that you can see there, they will still need to scan. But for those using the app on their smartphone, it's a real-time CGM now. A Dexcom One, again, another real-time CGM. And with Dexcom, regardless of whether you're using the app on the smartphone or the reader device, it's a real-time CGM regardless. So it doesn't matter what device you're using with that particular sensor. Slight difference is the Libra, you wear it for 14 days and it doesn't have an additional transmitter that you clip into it, whereas the Dexcom One, you can see there in the picture, there's an additional transmitter that you clip into the sensor, and that's reusable for 3 months, but the sensors themselves are worn for 10 days at a time. So slight differences. So we're going to talk a little bit about sort of interpreting the glucose data and how do we do that. And Kevin's already mentioned the two platforms for the two different products here. We've got Libra View for Freestyle Libra devices, and then we've got Dexcom Clarity for Dexcom One and their other products. There are some differences, but essentially they're both there to help us as healthcare professionals, but also our patients to view data and work in partnership, which we mustn't forget, to make clinically meaningful decisions. And I think when you first start, it can seem a little bit overwhelming because there's a lot more information than traditional capillary glucose monitoring. Looking at a handwritten blood glucose monitoring diary is very different to looking at some of the information that we will see on these platforms. But hopefully this will all become clear. Now, this is from Libra View, and as you can see, there are lots of different reports, but please don't feel that you need to know how to interpret every single report. They're all there, but you don't need to use all of them. And I have my favorites. Some of my colleagues have their favorites that they favor. You will come to know what reports you find easiest to look at and interpret. And I will sort of show you some of the key ones that I use today. That doesn't mean to say you have to do exactly what I do, but it's just sharing my sort of clinical experience. This is from the Dexcom Clarity platform. Oh dear, I've gone forward too quickly. This is from Dexcom Clarity, and again, similar amount of reports. They do look slightly different, but essentially it's still giving us the same information. So I've got a case study here. So I like to try and make it applicable to a real person. So this person is 72 years old. He's a builder. He's had type 2 diabetes for a number of years, on a basal bolus insulin regime. He's a builder, although he's mainly office-based, that obviously does prove difficult for regular glucose monitoring. And when he is active, obviously he does have risk of hypoglycemia because of the type of job that he's doing. So he was initiated on a Freestyle Libra 2. And I'm going to start with the AGP profile, which when I first started to look at them, I thought to myself, oh my goodness, what does that mean? So the AGP profile is the blue chart at the bottom. Let's focus on the top bit first. So we talked about time in range, didn't we? So if we can take a little look at his time in range metrics. So his time in range for the last 14 days is 38%. So if you remember the consensus guidelines, it's recommending sort of 70% or above as the gold standard. Now, not everybody can achieve that, but that's what we're aiming for. So he's at 38%. And this is his time above range, so 62% above range. The good thing is, though, he's not having any hypos. You can see there that his low and very low is 0%. We can also see what his estimated HbA1c is. So this is also known as glucose management indicator. And it's telling us that it's about 8.5% or 69 millimoles per mole. Now, this is based over 2 weeks worth of data, not 3 months. So it won't be exactly same as a lab HbA1c, but it gives us a good indication of what's happened most recently, because 3 months or 6 months is a long time from when somebody's had an HbA1c. So this gives us a more up-to-date indication of overall diabetes management. And then we can see here his AGP report, which the dark blue line running through the middle is the median. So that's where 50% of the glucose levels are falling. The darker blue shading is what's happening regularly, and the lighter blue shading is what's happening occasionally. And you can see here that really the target range there, his glucose levels are sitting in that point kind of in the early hours of the morning, but for most of the day, they're above that target range looking at that AGP report. So you can see here, that's where 50% of the readings fall. That's where his other readings are above target, and the shading generally shows us the glucose variability. So this is actually taken from somebody without diabetes. So this is what a near on perfect ambulatory glucose profile might look at. So you can see how it's quite different here. We're not going to get a 90% time in target with most people with diabetes, but that's just to indicate really what it would look like in an ideal world. So this is the daily report. I like looking at the daily report. This is one of my favorites. That's why I'm showing it to you. So if I just circle some of the bits here, so the red areas that I've circled is showing a trend, really a pattern. Now I know there's only a few days here, but a pattern of his glucose levels rising sort of after about 12 midday to around 2-3 in the afternoon. So that's a pattern that we can clearly see. And here, what's going on here? There's lots of gaps. Now this is before the Libra update, so he was scanning. Now the gaps in the data are because he was going for longer than 8 hours between scans. So the sensor only has an 8-hour memory. So if you're going for a longer period without scanning, it loses that data. So that's why it's really important for people still using the reader device that they need to scan regularly in order to save all of that data. So it makes it difficult for us to make clinical decisions when there are gaps in data. Hopefully now with the update with Libra, we won't have that issue with people using their mobile phones because it just sends the data automatically. The numbers here are when he's scanned, so we can see the individual glucose levels. The amber ones indicate when it's above range, and if there was to be a hypo there, it would be in a red square. So always important when we're looking at someone's glucose data, make sure that we go with a positive to start with. So he's not having any hypos. His time in target overnight is within range. But what could help? Well, he either needs to scan a little bit more if he can, or he needs to update his app to allow for the real-time CGM so that we're getting all of the data. It turned out that he wasn't actually taking his rapid-acting insulin with his lunch because it was perceived as quite a small portion that he was eating at lunchtime, but it was containing carbohydrates. So he was having Ryvitas for his lunch. In his mind, he thought because it was quite a light meal, he didn't require insulin to cover that carbohydrate. But actually, when you look at his glucose levels and the rise after lunch, it shows us really that he does need some rapid acting insulin with his lunchtime meal. So that's what we put in place. The other thing that might help is putting him onto smart pens or connected pens, because that will also link with Libra, the Libra app and Libra View, and it will be able to show us how much insulin he took and when he took it. And that helps us to decide on whether the dose that he's taking for the food that he's eating is appropriate, or do we need to alter it. So with the Libra update, this is what you'll see. This is not the same patient. This is actually my data when I trialed it with the update. But you don't see the individual numbers with the update to the Libra app now. These little circles in red, this is when the person is looking at their glucose levels. So you can see here on the first day, I looked at my glucose levels quite a lot. As the days went on, I looked at them less frequently. But the main difference is you don't see the individual numbers when someone looks at their data. You can see it's within the target range, that's the grey bit there, but you don't see the individual numbers. You only see the individual numbers when somebody scans. So somebody might scan if they've moved out of range of the Libra device and it's lost signal. It will prompt somebody to scan, and that will then save all the data that they've lost when they've moved too far away from their device. So that's it just takes a little bit of getting used to if you're used to looking at Libra View and then suddenly you don't see any of the numbers anymore. So I just thought I'd illustrate that for you. I'm just conscious of time. So this is somebody who's using smart or connected pens. So you can see there's lots of information here. This was before the Libra update, so they're scanning lots and many times a day. So these little white boxes here with the units in, that's the rapid acting insulin. And then the dark green is the basal insulin. And you can also see here when the person's eaten, identified by a little apple. And this here, these little white boxes here, are where they've actually done a capillary glucose level using the, I think they were using actually a reader possibly. So that's what connected pen data looks like. And that's really helpful, because that tells us how much insulin they took and what time they took it, and it just gives us more information, and it helps us to adjust the medication with greater detail and more safely, really. So I'm going to run very quickly through a Dexcom 1 case study. So this is a 75-year-old lady, also with type 2 diabetes. Now, she was on basal insulin once a day via the district nurses. Kevin was talking about how this can be really advantageous for certain groups of people. So the district nurses were going in to see this lady at 1 in the afternoon and giving her insulin. And before she went on to Dexcom 1, they were checking her glucose levels once a day. Very difficult to titrate or manage that insulin with 1 glucose level a day. And at 1 in the afternoon, it's more than likely going to be a postprandial glucose level. Very, very difficult and not particularly safe to be titrating background insulin on 1 glucose level a day. So this lady wasn't able to self-monitor, but she was able to use a Dexcom 1. No scanning involved, obviously. She just needs to look at the device and it tells her what her glucose level is. Her last HbA1c was 53, and that was 6 months ago, but she'd been complaining of some dizziness in the morning and she'd had a couple of falls overnight. So this is what the Clarity data looks like. So if we first look at her time in range is fantastic. It's 83%. And we look at her average glucose, that's very good. But when we look at her time below range, it's 11%. And for somebody of that age who lives alone, who's potentially frail, there's too much hypoglycemia going on there. So if we remind ourselves, for older and high-risk patients, we're looking for time in range of about 50%. So she's way over that, which is great. But the time below range, really, we only want it to be 1% or less, and she's up at 11% there. So we definitely need to do something about that. Her estimated HbA1c, well, that's probably a little bit too good, really. And that's reflected by the amount of hypos that she's having. It also tells us, it shows us there some patterns of this particular lady as well. So this is the AGP from the Clarity report. I know it looks slightly different. It's not blue, it's color-coded, which is quite nice. And you can see here that she's having lots of hypos, mostly overnight, between the hours of about 1 a.m. right through to sort of 8, 9 a.m. in the morning. And you can also see with her daily glucose profile there, all the red bits that are dipping below that target range are hypos as well. This is the patterns report. So this is quite a nice report because it actually highlights the patterns for you. You don't need to go looking for the patterns. It's already done it for you. And it also gives us some ideas about what we might want to do with this lady. We might want to consider adjusting basal insulin. She's not actually on any mealtime insulin, but if she were, it's telling us that we might need to consider that. And we might need to look at what's happening in her routine. Was she having a bedtime snack and she suddenly stopped having a bedtime snack? Has she lost weight? Is her appetite reduced? All those sort of questions we need to ask. Also, when I looked at her data, I realised that her alarm settings were turned off. And we haven't really talked about alarms, but both of these particular devices have optional alarms. So you can set the alarm to make a noise when the glucose level is too low, but also if it's too high. And when I checked her device settings, they were all turned off. Now, was that because she didn't know how to set them in the first place? Or was it because they were waking her up every night and she got really annoyed with them, so she turned them off? The DTN have some good guidance. So the DTN UK website have some good best practice guides, and it tells you at what level to set your alarms for your patients. I think my slides have got a mind of their own. So here it's like a little flow chart, and it can tell you what level is appropriate to set the alarm. So that's worth a look if you're not sure what alarm settings to set them at. Certainly for a lady of living alone on her own, of that age, I'd probably set the alert somewhere between 4 and 4.5. So again, with this lady, what's gone well? Well, her time in range is absolutely fabulous. She's using the device with no problems. We've identified that hypoglycemia is a problem. We maybe need to look at her background insulin dose and reducing that. We need to turn on her alarms to keep her safe. And we need to just explore whether that bedtime snack routine, has it changed? Has she stopped having it? So this is my little guide, step-by-step guide. And this is partly because the starred items there are in my clinic template letter. It asks me to document a time in range, time below range, time above range, estimated HbA1c, and how many scans or views per day. But then the other key reports I would suggest using, the AGP, daily report, and the weekly summary is quite useful. And then if you're using Dexcom, if you're on Dexcom Clarity, the patterns and trends reports are also quite useful. Just a reminder from Prescribing Perspective, we still recommend a small supply of blood glucose monitoring strips in case of sensor failing or hypos or symptoms that don't match the sensor glucose. If somebody's unwell or they can't get hold of their prescription. So make sure that they do still have a small supply of testing strips. And a sharps box needs to be big enough not only to put the applicator in, so you need to have a decent size sharps box, but you also need a sharps box with a hole at the top that's big enough to get the applicators in. Certain brands do not fit in the Dexcom One sensor applicator. So the one pictured there, I think that's Sharp Safe. They have much bigger apertures at the top than the Sharps Guard, which are the round ones. And that's me done. Thank you very much.
Great. Thanks so much, Vicki. So yeah, apologies, just ran over a wee bit, but I think Hope, now are you going to facilitate some of the Q&A?
Yes, I'm just getting the Q&A up. So I think the first question was about the update to the Libra, but I think we've covered that one. So yes, the update to the Libra means that no more scanning if somebody's using the app on their smartphone.
Yeah.
But if they're using the reader device, unfortunately, they still need to scan.
Yeah.
There is a question here for you, Kevin. Please, could you repeat why anemia has an impact on HbA1c?
Oh, yeah, I mentioned that, no problem. So anemia, particularly iron deficient anemia, your red blood cells live for longer. So that means they're circulating for a longer duration of time. So they're exposed to glucose for a longer duration of time in the blood. So you get an artificially elevated HbA1c. So someone with an iron deficient anemia will have an HbA1c higher than they should. Whereas conversely, in bleeding disorders, your red blood cells live for a shorter duration of time. So they circulate for a shorter duration, they're exposed to sugar for a shorter duration, so you get an artificially lower HbA1c. So that's why, as Vicki has also said, treat the person, not the number. If there's a clear mismatch between what that person's HbA1c is and what they've been doing, changes in their lifetime, just look a wee bit further. Could they be anemic? Or sadly, is there a more sinister diagnosis, pancreatic cancer, something like that? That can also, cause artificially or abnormal HbA1c. So just be aware, HbA1c is not a perfect tool. There are a number of pitfalls as well.
Yeah, lovely. Thank you, Kevin. So another question here for Libra View and Clarity. Do we have to have a data sharing agreement? So it's the patient's data at the end of the day, and it's up to them whether they share that data with you. So when you set up your own Libra View account as a GP practice or as a specialist service, wherever you're working, there is a code that you share with your patient. So it's up to them whether they decide to share that data with you. So it's essentially their data. If they decide to share their data, then absolutely, that's grand and fine. But what I would say is you need to make it clear to them that then you as a healthcare professional is not going to be alerted every time they look at their data, every time they have a hypo, every time they have a high glucose. It's not going to pop up in your inbox. It's literally there for you to log into and to review as part of your diabetes management process prior to annual reviews, reviews in between their annual reviews, if you're titrating someone's insulin, for example. So I think you just have to manage that expectation with your patients so that they don't assume that you're constantly watching them. Because I've had a few people say to me, it's a bit like Big Brother, but that's not how it works. It's their data at the end of the day, and they consent to share it with you. So hopefully that answers the question.
And that's definitely been a concern of colleagues of mine in primary care. As we are initiating CGM in primary care for type 2, are we going to have to log into all these data and review this data on a daily basis? We're in, and absolutely, as Vicki say, the answer is no.
And a question from Kirsty with regard to the update to the Libra. Do patients need a newer or updated sensor to make it real time rather than intermittently scanned? The answer is no. It's the same Freestyle Libra 2 sensor. It's just the app that's been updated, not the sensors themselves. So they can carry on with their normal Freestyle Libra 2. sensors. So it's just the device that they're using. So that's nice and easy. And also from Kirsty, are smart pens available on the NHS? So yes, they are. Yeah. There's only one company at the moment that make the connected pens. There are more coming, but it's the Nova Pen 6 and the Nova Pen Echo Plus made by Novo Nordisk. Most of your representatives will give you a pen, 1 pen per insulin for you to give to your patient.
Yeah.
It's always recommended to have a spare pen though, so that can be prescribed by FP10, because they always need a backup pen. If that pen that they're using suddenly breaks or stops working, they've got no other means, because they use cartridges within the pens, they've got no other means of administering their insulin. I think we've got time just for a couple more, hopefully. Hope can tell me if that's not the case. Is it okay to use Libra for a 2-week trial on basal insulin? Certainly anyone can request a free trial. You as healthcare professionals can request a free trial for a Libra for 2 weeks. That's the best way to learn. So you could use it for a 2-week trial on a patient on basal insulin, for example, but you've got to bear in mind what's going to happen after that 2-week trial. Is it something that would be beneficial long term? And is that going to fit into your local guidance as to whether you're going to be able to continue to prescribe it? But certainly, yes, we've put sort of 2-week sensors on just to get information over a short-term period if that's what was felt that was needed. Right, I need to put my glasses on for this one.
Oh, yeah, this is the question from Andrew Swift. Yeah, I'll pick up this one. No, I completely agree with you, Andrew. This is a significant concern locally among my GP colleagues as well. The potential significant increased workload associated with CGM, insulin titration, adjustment, etc. So what we've done, and to be honest, just me and a few other practices, is starting where there's greatest advantages to have. And as I've mentioned already, we've been working with our our district nurse team to help them, our patients who are requiring insulin, home visits to get their insulin administered. We've been starting CGM in there to help their workload as well, reduce their workload. And as Vicki took us through in a case study, to allow safer titration of insulin in that respect. But that can be, I have an interest in diabetes. I've been largely doing that ourselves, but our local DSM's very much on board as well to help advise on that the CGM data that Vicki has taken us through. I've also been using it a little bit in the care home setting as well to de-escalate therapy because, again, of safety issues. Like Vicki also took us through, some patients of mine who hadn't been taking their insulin regularly or for a number of reasons are now in care home settings where they've got a very high time in range, but a very significant time below range too. So it's been very helpful in that context as well. So I think absolutely, we need an MTD approach using the expertise of our DSM colleagues, and and trying to pick areas that will most benefit ours or our colleagues' workload, and also ultimately help improve the lives of our patients. So the resources are highlighted just towards the end of my section. They're a good starting point, just as an introduction to CGM in primary care, as these webinars aim to be as well, and also some top lines like Vicki's very helpfully taken us through about interpreting that CGM. So you're going to get a copy of all, all the slides. So you'll be able to access those resources via the QR codes I put on the slides.
And I think it can be overwhelming when you first start using this type of technology. But given the choice personally, once you start using this and then you go back to seeing somebody who's capillary glucose monitoring, you feel like you're looking at their data with one eye shut, because you're so used to all the extra information, and it really, probably the setup and everything that you need to learn in the beginning is a bit overwhelming, but once you're up and running, it's so much easier to make clinical decisions because you've got so much more information. And then you go back a step and you look at a blood glucose monitoring diary and you feel like you're sort of, you haven't got half the information. So given the choice, Vicki, I would go with that data all the time.
Yeah. But you did admit in your own words as well, it's been quite a learning curve for you as well, hasn't it?
Yeah, of course. Yeah. Yeah.
Absolutely. So, and again, that goes back to Andrew's and others' comments too. It's going to be a learning curve for us all, and it's absolutely not for everybody. But, for the right patient, it can be transformative, can't it? For the right patient living with type 2 or type 1, definitely, but even type 2 diabetes as well.
Yeah. Very last question. Is there a program to observe how to set up a Dexcom 1 or Libra 2? So both of the companies' websites have educational resources, not only for patients, but also for healthcare professionals. And also, I work within the Eden team, and there is a glucose sensing to primary care online program, which is free to register for any healthcare professional, and it talks you through both products. So you can, if you Google glucose sensing in primary care Eden, it will bring up the resource for you.
Good stuff.
Brilliant.
Great. I think that brings us to the end. Thanks everyone for listening. Thanks so much, Vicki, as well for your input. So I'll hand back to Hope there. Thanks for joining us.
Thank you both so much. That was really interesting. You can see by the thank yous coming in the comments as well that everybody has enjoyed it. So really appreciate that. Thank you.